Hello, listeners. A very warm welcome to season 7 of the Big Unlock podcast. My name is Ritu M. Oberoi, and I'm the managing partner here at Big Rio and Demo Consulting, and I'll be your host today for the Big Unlock podcast. Today, we are really excited to welcome Dr. Dhruv Khullar to our podcast. Dr. Dhruv Khullar is a practicing physician, health policy scholar, and one of the most thoughtful contemporary voices examining the intersection of medicine, technology, economics, and the human experience. As an associate professor at Weill Cornell Medicine and a contributing editor for New Yorker, his work explores everything from corporate consolidation in healthcare and Medicare Advantage to AI, physician burnout, public trust, and the changing identity of doctors in modern society. So we're really excited to have Dr. Kuller with us here today. Very warm welcome to you.
Thanks very much. It's great to be here.
Would you like to add anything to your introduction, or did I
No, that was perfect. Very comprehensive.
Thank you. We usually love to start with an origin story and just hear about, what brought you to medicine. And usually we get to hear really interesting, personal anecdotes and insights. So would love to hear how you got into writing and, medicine.
Sure. So my father is a physician, and so I grew up around medicine, and I saw the relationships that he had with patients and the way that he was able to help people through some of the most challenging times in their lives. And I knew from a very early age that's what I wanted to do. I wanted to see patients. I wanted to learn about medicine, but really apply medicine in a way that would be able to help people in that way. And along the way, I got very interested in all the forces around healthcare. As I went through college and then medical school, it became clear that the kind of traditional model in which physicians had been practicing for decades was changing. And part of that was political, part of it was economic, part of it was cultural. And I really wanted to find a way to understand all these forces. And so I ended up taking, a year and a half away from medical school and doing a public policy degree and started writing about not just medicine, but about public policy as well. And found that writing was a way that I could both understand the system more deeply, but also communicate about it to patients and clinicians and the general public.
Yeah, thank you so much. I've been reading all your articles in New Yorker and really enjoyed, understanding and looking at some of your perspectives. And we'll talk about some of those as we go along in the podcast. But, one lead in which I get directly from what you talked about is that medicine is now, kind of losing or maybe changing its status as the singular authority in health. And doctors are now competing with influencers, algorithmic startups, and, political movements for public trust. So in this era where we are seeing this, direct to consumer startups increasingly shape health decisions, how do you see the role of the physician evolving over the next decade, and what do you think is changing, and what's going to happen to the role of physicians?
This is such an important question. And I think a good way to start is to think about the way that medicine was practiced in the 20th century. And at that time, medicine really was a hegemon of sorts. It had a near monopoly
Mhm.
on access to medical information, to the delivery of medical care, and authority and legitimacy about issues that involve people's health. And all three of those things, authority, delivery, and information, have started to shift in the 21st century. And some of that is, as you mentioned, because of political movements and other actors that are now claiming authority. Some of that is because of social media and the way that people are now getting their information. Social media is a really important example, but also, Dr. Google and artificial intelligence increasingly now. And part of that is because of other types of care delivery models. And part of that might be, let's say, direct to consumer companies, other types of telehealth or online practice of medicine. And so, in this environment, medicine really needs to think about how to shift its role. And it's not going to be the way that it was in the 20th century. We need to be much more agile in the way that we partner with other organizations, much more persuasive in the content that we are putting out. It's not enough to kind of dispense the doctor's orders, but we really need to provide rationale and perspective and kind of understanding of why some recommendations are being put out there. And I think we need to be much more involved, not just in the practice of medicine, but in the issues that surround the practice of medicine that influence the way that we're able to deliver care. And some of that might involve, consulting with, those in public office or running for office ourselves. Some of that might be working with startups or other healthcare organizations. Some of it might be active on social media. It will be different for different members of the profession. But I think, it's not going to be enough to kind of close our eyes or abdicate our public role in that way.
Yeah, I think that's a very interesting answer because I was reading one of your, very early articles. I think it was New York Times where you said doctors really have to be leaders as well. And you were particularly talking about, the floor, the cardiology floor, where you said when something happens, everybody rushes, but then, the role of the lead doctor is to really be the leader and tell people what to do. So that's a very I think a very interesting perspective that you now have to lead with these new technologies as well. So that kind of leads into the next question where, you know, you've written so many articles about how medicine often adopts technologies long before it fully understands their second order consequences. So now with generative AI and artificial intelligence moving from, admin support into clinical reasoning, patient communication, and even emotional companionship, where do you think this, the healthcare industry is currently underestimating the societal or psychological impact of AI the most? Because it's coming, like you said, Dr. Google, now with OpenAI and Anthropic, everybody coming into healthcare, nobody can stop the freight train now. So what are your perspectives there? Would love to hear from.
Yeah, well, patients certainly and clinicians are going to be using AI because it is so convenient and so fluent and so present now. And so, whether we like it or not, this is something that's going to increasingly be part of the healthcare system. And I think it's our responsibility to figure out how to harness its potential while minimizing its potentially adverse consequences. And I think some of that requires insisting on a certain level of evidence of efficacy. So there are so many claims that are being made about AI today that can make care safer or more efficient or more accessible or accelerate drug discovery. All these things are possible, and I hope that they are the case. But they are claims that we need to meet with a certain level of evidence and data so that we are confident that in fact these types of things are happening and before we roll them out across the system. So I like to think about AI in a few buckets because it's so easy to have a conversation where one group of people are talking about X and another group are talking about Y. And I think, as you mentioned, one of the first areas that AI is going to make a big impact is in the administration of healthcare. And I think things like documentation and billing, we're already seeing AI scribes in many healthcare systems around the country. And so I think that is an area of great promise. I think another area is patient navigation. I think as clinicians, sometimes we underestimate how difficult it is to make your way through the medical system, whether that's making an appointment or engaging with a health insurer, figuring out how to pay your bill. All these things, AI has a real potential to impact in a positive way. Drug discovery is another area that I'm very optimistic about. Many, probably all pharmaceutical companies, many biotech companies are now using AI to try to understand, let's say, the folding of proteins or scouring chemical spaces to unearth interesting molecules that are worthy of further study. And then finally, of course, as clinicians in the care delivery space, assisting with clinical decision support, precision medicine, treatment modalities, all these things I think will be influenced and improved with AI. But again, we need to see the data and we need to understand as we're rolling these things out, what is the ultimate impact in terms of improvements for clinicians and for patients.
Yeah, I think with all our conversations with C-suite leaders, over the last year or so, that's exactly the direction we are seeing, that there's a lot of like now acceptance around, this AI or the digital front door where it's pretty much established now. So that covers the patient navigation and, like you said, the scribes and the ambient. But now when it's moving into clinical, I think that's where, some of these trust and ethics issues are coming in. Like, where do you draw the line? Do you still keep human in the loop? Do you let AI do its thing? So it would be interesting to see where all this is heading. So where do you think, how do we kind of maintain empathy in this system? Because if you're trying to scale this, you kind of start losing the human connection. So do you think that healthcare is at a risk of optimizing for convenience so aggressively that we're actually accidentally kind of almost engineering empathy out of the system? Or how do you think companies
Well,
are looking at this?
I think we've already done that. So we are already in a place where we've engineered empathy out of the system
Mhm.
because medicine has become, I think, such a business and so focused on efficiency as defined by, let's say, number of visits per hour. And so I think AI potentially has a real opportunity to get back to empathy.
Mhm.
If we are able to take some of the things that detract from the clinical interaction,
Mhm.
things like coding and billing and documentation and data collection and reporting, all things that have a place, but that clinicians and physicians should not be necessarily the ones doing it. If we can automate some of that, it opens up a space where more of the clinical interaction can be focused on really engaging with a patient. We've already seen that in some respects with AI scribes. Many of my colleagues who have used scribes now feel like they're able to look the patient in the eye, focus their attention on them in a way that they weren't able to even just a few years ago. Now, I think this has to be paired with a cultural change. I mean, we have a technological revolution that is going to create the space potentially for more engagement with patients. But you could easily see that the mandate becoming, okay, now you have more time, so you should see twice as or three times as many patients in the same
Right.
unit of time. And so, if we want to create a space where actually that extra time is now being devoted to engaging patients, to understanding them more deeply, to addressing some of their concerns in a way that we weren't able to in a 5, 10, 15-minute visit. We have to fight for that. And that has to be part of what's happening as these technologies enter clinical practice.
So, yeah, so exactly, what you're saying is that patients are not necessarily rejecting medicine. They're just rejecting feeling unseen, rushed, or, processed by the system. So maybe the next great healthcare breakthrough might be less about a new technology and more about bringing back this sense of, relationship and trust and care. And that's what
Yeah.
we've been hearing about ambient a lot from the doctors, that they're actually articulating more because now they know that the scribe is kind of writing everything down. So they're telling the patients more. And maybe as a side result, the patients are feeling more heard and feeling, that there's more value in that relationship. So,
Yeah.
Dr.
And I
Khullar.
should note that um, there are some types of care and some patients and some interactions where people may be okay with a more transactional relationship. If people want to prioritize convenience, if it is a low acuity condition, if the risks are relatively minor, if they just need something quickly, maybe those are places where AI or AI distantly supervised by a clinician will ultimately be the right care model. It's not the case that every patient wants to be seen and heard in every interaction. Sometimes you just want to get what you want and get on with your life. But for a lot of people, for more serious conditions, for things that require a greater discussion of trade-offs between, values, integration of the clinical evidence or the guidelines with your own preferences, there are all sorts of areas and conditions for which I think people really crave that deeper understanding.
So we can change tracks a little bit just to make it more fun and kind of ask you about how you get ideas for your stories. You write on such a wide variety of topics. How do you are you just very observant? Do you note things down quickly, or how do you get these ideas and say, okay, that's going to be my next story?
There are a few main ways. Part of my many ideas come from my clinical practice. And so when you're seeing patients in the hospital, you're seeing the way in which various things are affecting their lives or the challenges that they are going through, um, those naturally spark a number of ideas of how and why is it the case that someone's going through this? What are the challenges that they're facing? Are there things that we can do to unstick the process? And so I think one big bucket of ideas comes just from seeing patients and understanding what they're going through. I
Mhm.
think a second is following closely the research in a particular space. And so whether it's let's say CRISPR or GLP-1 medications, when you're reviewing the medical literature, and naturally there are moments that you say, this new paper is a big deal. We're seeing something that we didn't realize before, or a particular body of work is maturing and it deserves greater attention. So I think the second big bucket is reviewing the medical literature quite closely. And then the third is understanding political events and current events. There might be a new policy that is being proposed or a new reform of some sort, and certainly understanding the specifics of that and being able to synthesize that information for people and present it in a engaging way is probably the third big area.
Yeah, I just read your article about peptides today, and I was like, what?
That's a good
Didn't
example.
know
Yeah,
anything
yeah.
about that. Yeah, so that was interesting. So, how do you keep yourself updated about technology, especially with things moving so fast? And even people who are in this field and, currently working on technology, they're like finding it hard to keep up with all the new models and everything being announced every single day. So, you are so busy as it is. So, how do you manage to do that?
Well, as you say, it's hard for even people who are spending, their entire day to keep
Yeah.
up with the technology and the rate of change. And we've never seen, I think, anything quite like this, both in terms of the advances in the technology, but also the adoption of the
Mhm.
technology. So I try to have as many conversations with people as I can, people who are at the forefront of these technologies, who are living and breathing them every day. Speaking with them, understanding what's on their mind, what are the challenges are. That is certainly an area that I devote considerable amount of time and attention to. I think the other big way is, to read again the medical literature and see the ways in which these technologies are being applied, what the evidence base is, how things have shifted from just a month or two, and what's new. But I think the other thing to point out is often what I'm trying to do is not follow the ins and outs of every change every week. I'm trying to see the bigger picture in some way. And so, stepping back even and taking a 30,000-foot view of where we've been and where we are now and where we might be going, that allows kind of a way to see the big picture and as opposed to getting lost in the minutia of the everyday changes.
Yeah, so most of the organizations we've talked about, in the last 6 months or 1 year, they've seen this position of the chief AI officer or, the chief digital and AI or digital transformation officer. So tell us a little bit about your organization and the approach there to digital literacy. I mean, you have a particular interest and you are able to keep up, but what about other physicians? Are they being trained on this? What's the organization's approach to digital literacy or AI literacy in your
Yeah.
organization?
I think we have a very thoughtful approach, and it's one in which, for instance, there are sessions so that, doctors and other clinicians can understand the potential of the technologies, the drawbacks of the technology, how to integrate them into their own clinical practice. Some of that is very kind of focused on how do we make the most of, let's say, diagnostic support, and then use that in clinical care. But some of it is also focused on education. How should we be teaching the next generation of physicians about, these technologies and how to use them in their own critical thinking?
Mhm.
And there, I think, we should take probably a fundamentally conservative approach where this is a potentially very powerful technology, but it's still essential that medical trainees retain the ability to think through a case independently and
Mhm.
use, I think, AI more as a second opinion than the primary way in which they're reasoning through a new patient encounter.
Mhm. So you think that, the old methods still should continue till this thing is proven more. Is that your approach? Or
Yeah, I mean, I think we should enthusiastically evaluate the potential upside of using AI to support clinical care delivery. But I
Mhm.
think sometimes there's a narrative that all a physician has to be these days is an empathic person, and the AI will do all the thinking
Mhm.
for you. And I think that's not at all true. I think
Yeah, we're
the
not there
pace of
yet.
medicine
Mhm.
is such that you need to keep a lot inside your head in order to care for patients. And it's also the case that in order to properly adjudicate the AI's output, you
Mhm.
have to be the one exercising the judgment, when to ask another question, how to evaluate whether it's telling you is true, whether it applies to the patient in front of you. All those things, I think, still need to be things that physicians are very skilled at.
Mhm. I agree. I think we're still a long way from there. So that's going to take some time. So you've, Dr. Khullar, also written compellingly about medicine entering a kind of gilded age where you think, this extraordinary innovation coexists with this deep public distrust and worsening inequity. So do you think healthcare today is facing primarily, what type of failure? Is it a policy failure, a moral failure, or a narrative failure, or which one do you think is the hardest to fix? Like, where do you think that problem lies?
I think that medicine has become primarily a business.
Mhm.
And I think we need to have a countervailing narrative in which it's seen more properly as a craft or something that is done in the best interest of patients. And that's the primary reason that
Mhm.
we are going about doing what we're doing. That's not to say that medicine should never think about money, that doctors haven't always had certain incentives, healthcare organizations, hospitals. Um, but I think there's a feeling, both among healthcare workers and among patients, that somehow the primary motive now is figuring out how to extract the most profit,
Mhm.
and not how to deliver the best care. Um,
Mhm.
some of that is, I think, an internal failing on the part of healthcare providers, and some of that is the result of outside forces, more corporate forces, that are entering medicine and don't have the same professional ethic that doctors, nurses, other clinicians have been trained in. I think this is reaching a point where there are now policies that are being introduced or passed to push
Mhm.
back on
Mhm.
some of the corporatization. So some states have passed legislation requiring, let's say, physician majority ownership of medical groups as opposed to private equity or other forms of corporate ownership. And so I think there's a recognition now, and I think there's an appetite to start to push back against what I see as kind of an overly commercialized healthcare space, but we are still at the beginning of that project.
Yeah. So, would you like to share some thoughts on value-based care? I know you like to talk about that.
Yeah. Well, value-based care, I think, is a very powerful tool, and it's one that we are have been trying to apply for the past several decades. Notably, after the passage of the Affordable Care Act, it became a pretty central way in which Medicare has been thinking about paying physicians and other healthcare organizations. Um, But I do think there are a lot of challenges with the application of value-based care, and it hasn't been the slam dunk that people thought it might be a
Mhm.
decade and a half ago. A lot of that has to do with how the incentives are structured, and the unintended consequences of
Mhm.
introducing these types of incentives. Let Take, for example, risk coding. One way to if the way that you're comparing and incentivizing healthcare organizations is by comparing their outcomes to their neighbors' outcomes. There's a real incentive to capture as many diagnoses for your patient population so they look as sick as possible. And Therefore, your risk adjusted outcomes might look better than a neighboring health system. So that's one example. Another big criticism, I think, has been that some of the metrics that have been introduced are relatively narrow or might be seen as irrelevant, particularly for certain specialties. So, in all these ways, I think there have been serious challenges to the value-based payment shift. But overall, directionally, I think it's still the right way to go.
Mm. Maybe AI will be able to fix some of these with, the technology coming in. And that would be a really good full circle moment, I think, if it's able to influence some of that. So we're almost end of time here, Dr. Khullar. It's been a really good conversation. Would you like to leave us with any closing thoughts or, any, like in the next 6 to 12 months, what do you see happening? Any predictions or, future trends? We would love to hear from you.
Yeah. Well, I just want to, say that how grateful I am to have joined you today. I think these types of conversations are so important. One of the things that we need to be more focused on as a medical profession and public health system is figuring out how to have conversations with one another, but also with the general public. And I think that communication and good storytelling and speaking simply and clearly and forthrightly is a really important part of where we need to be going as a healthcare system. So thank you for the opportunity.
Thank you so much. It's been a pleasure having you on the podcast today. Thank you, Dr. Khullar.
All right. Thanks very much.